Greetings and salutations, everybody. The topic of our discussion here is going to be epilepsy in pregnancy. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right-hand corner of the screen, and that should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, as well as how to formulate a differential diagnosis and treatment plan, things that will come in useful to you as you gear up to study for Step 3 of the USMLE or for clinical practice in real life, which, as you know, in real life, patients don't come with a multiple choice set on their head. It is an open-ended test. Alright, so we are going to do a quick overview. We'll talk about some of the risks associated with the pregnant epileptic woman. We'll talk about the preconception management, which of course begins before she gets pregnant. We want to make sure she's medically optimized. We'll talk about the anti-epileptic drugs, which is really the meat of our discussion because it's the anti-epileptic drugs that cause us the problems that are associated with these risks, especially as it applies to the fetus. We'll talk about the management during pregnancy and delivery, how we take care of these women while they're pregnant. We'll talk about the woman who has her first seizure during pregnancy, which offers us a little bit of a conundrum because we need to know where it's coming from and we need to manage her, which can be difficult to initiate in pregnancy. We'll talk about postpartum management and then we'll summarize things up as we conclude. So about 0.5% or 1 in 200 pregnant women have epilepsy that we know of, and that jives with the overall prevalence in the general population, which is somewhere between 5 and 8 for every 1,000. So when you figure half of those are women, that works out to be about what we would expect. About 90% of women with epilepsy, however, do have a normal pregnancy. And so if a woman comes to you and she asks, is it a good idea if I get pregnant because I have epilepsy? Well, the first thing you want to ask her is, how well controlled is your epilepsy? When was the last time you had a seizure? Because it's the control of her epilepsy that's really going to determine whether she falls into this 90% or if she's in the 10% who do have complications. So epilepsy itself is not a contraindication for pregnancy. It's not something like Eisenmenger syndrome or pulmonary hypertension where we really tell those women it's a bad idea to get pregnant. Epilepsy is not like that. These women can get pregnant, and they do get pregnant, and it's totally fine, but they do have slightly higher risks of some bad things to happen. So what are those risks? Well, the highest risk is maternal death. We see a much higher prevalence in the epileptic population compared to the controls, with an odds ratio of about 11.5. And what this probably is due to is the fact that with pregnancy, the physiology is changing, and it can be difficult to keep her anti-epileptic drug levels at the level that is effective. And so she may slip under the therapeutic range, and that would be a problem. That's one of the major things that we're looking out for, and it's why any woman who has epilepsy who is pregnant needs to schedule a visit with her neurologist. Some of these other things here, you see postpartum hemorrhage, some of the hypertensive disorders of pregnancy, slightly higher risk, but not dramatically higher. So all women of reproductive age should be on supplemental folic acid. That goes for everybody. All women, regardless of their health problems or lack thereof, they should all be on daily folic acid. The general recommendation is 0.4 to 0.8 milligrams per day. However, women who have epilepsy should be on a higher dosage, and the reason is because we want to prevent neural tube defects. That's the whole point of taking preconceptional folic acid. Now you might ask, why would a woman with epilepsy be at a higher risk of giving birth to a baby with neural tube defects? And the answer to that is that they're not. It's the medications they're on that increase the risk. And so for this reason, ACOG recommends that all women who are at risk for having babies with neural tube defects, which includes women who are on anti-epileptic drugs, and that being said, it doesn't necessarily need to be for epilepsy. If they're on anti-epileptic drugs for bipolar, like Lamictal, for instance, they need to be on a higher dose of folic acid as well. So this really applies to not just women with epilepsy, but really all women who are on anti-epileptic drugs for whatever reason. Medical management of epilepsy should be optimized prior to the decision to attempt pregnancy. So we want to make sure that her epilepsy is under control, that she's on her medications, that she's compliant with them, and that she has scheduled a visit with her neurologist to get clearance to become pregnant. Now, a lot of women are going to come to you and they're already pregnant, and so some of this is going to be a moot point. But when you have a woman who comes to you who has epilepsy saying that she is thinking about becoming pregnant, then the onus lies on you to make sure that she is well managed and that her epilepsy is under control before she makes that decision. Because once she gets pregnant, things get a little bit more dicey. And the worst thing that can happen is that she has epilepsy, she gets pregnant, and then she has a seizure. Seizure and pregnancy do not go well together. It's really bad for the mom, it's really bad for the fetus, and so we like to make sure that these women are medically optimized prior to becoming pregnant. Women who have epilepsy need to be counseled regarding the unique risks that the pregnancy will pose to them and to their baby, but they should also be reassured because 90% of women with epilepsy will have normal pregnancies. So it really comes down to giving them the facts, but also reassuring them that for the vast majority of women with epilepsy, they're going to have normal pregnancies. What it really comes down to, though, is their compliance and that they're coming in for good prenatal care. That's going to play a crucial role, as I said, in making sure that they're part of that 90% and not part of the 10%. The anti-epileptic drugs are very, very diverse. There are tons of different anti-epileptic drugs, thankfully, and they all have really different mechanisms of action. So none of them work in exactly the same way as far as the classes of anti-epileptic drugs. And as you can see here, there's a lot. So these are the commonly used anti-epileptic drugs, but if you look up in a pharmacology textbook, you'll see that there's a lot more than just this. Now I put some of these here with a star, and the reason that I put a star next to them is because you will see these ones prescribed very commonly in women who have bipolar disorder. And so here we're talking about women with epilepsy. But a lot of this applies to women with bipolar disorder because some of the risks, we're not worried about her having a seizure, but the risks to the fetus that come from these medications apply all the same to women with bipolar disorder who are being treated with mood stabilizers, which are just anti-epileptic drugs. The risks are going to apply to them too. And so you see Tegretol prescribed a lot. You'll see Topamax, you'll see Lamictal. Those are very commonly given in bipolar disorder. Depakote you will not see very often anymore because psychiatrists and neurologists realize that it's really a sticky situation if you have a woman on Depakote and then she gets pregnant. Now you are dealing with very serious risks to the fetus. And so for that reason, we don't really give Depakote to women at all anymore. We actually don't even give Depakote to females who are not menopausal. And the reason for that is because Depakote has been associated with polycystic ovarian syndrome when given to young girls. So usually we keep Depakote for postmenopausal women and for men. Some of these here I put with a caret. These are given for neuropathic pain as well. And then Topamax is given for a few other reasons. It can be given for the prophylaxis of migraines, and it can be given as a medication that helps with smoking cessation as well as for weight loss. So there's a very diverse application of these medications, and you have to bear in mind that not every woman who's on these medications has epilepsy. So it's very good to get a good medical history on any woman who comes in who's pregnant or wants to become pregnant, and keep an eye out for these medications, which all have either documented or theoretical teratogenic potential. Fetal malformations are a major concern with anti-epileptic drugs, the prevalence going from 3% in the general population up to over 10% in women who are on these medications. As I mentioned, Depakote is probably the most teratogenic and really should be avoided whenever possible. We really just avoid giving it to females in general, though. Dilantin, Tegretol, Topamax, and Phenobarb have all been documented with higher baseline rates of fetal malformation. So those ones we know for sure have teratogenic potential. Some of the new ones, like Keppra, for instance, we don't know whether or not it is teratogenic. It probably is a little bit, but we don't know. So when you see some of these newer agents, you may think they're safer, but we don't really know. But they may actually be safer. So because we don't know, some neurologists will try and transition women who want to become pregnant. They'll try to transition them into some of these newer agents. So rather than taking a known risk, we're kind of venturing into the unknown where it might be safer. And so that will be really a decision between the woman and her neurologist. As a general rule of thumb, for any medication, the patient should be on the lowest effective dosage, the dosage that prevents her seizures from coming back. And this bears repeating again and again. The best anti-epileptic drug regimen to use doesn't have anything to do with what type of medication. The best regimen is the one that is most effective at preventing seizures in a given patient. So you're much better off with a woman on Depakote than you are, for as bad as Depakote is, you're much better off with a woman on Depakote than you are with a woman who's pregnant and having seizures all the time. Seizures are way worse than any of these medications. Seizures can be deadly both to mom and to the fetus, whereas the anti-epileptic drugs, yes, they can cause some fetal malformations, but what would you rather have? A dead mom and baby or a baby with congenital malformations? And you can make your pick there. Now, if a woman who wants to get pregnant decides, well, I'm not really comfortable with the medications that I'm on and getting pregnant, then she can consult with her neurologist and they can potentially discontinue or reduce the dosage, or they can change anti-epileptic drugs. All of that stuff is fine and good as long as she's not pregnant yet. So this is fine to do prior to pregnancy. And we recommend that it be done 6 to 12 months prior to conception, because anytime you start changing the dosages or changing the medications or discontinuing the medications, there's a high risk of seizure recurrence, and it's between 15 and 30%. And usually this is going to happen within the first few months of changing those medications. So because we don't want a woman pregnant and having seizures, we recommend that this be done several months before she attempts to conceive, so that if she does have a seizure, it's before she's pregnant. Because like I said, it's having a seizure and being pregnant is worse than just having a seizure. It comes with all sorts of additional problems. Some miscellaneous notes. This doesn't really have anything to do with obstetrics and childbearing so much, but it does have some gynecologic importance. Anti-epileptic drugs are inducers of the cytochrome P450 system, and so because they are inducers, they will speed up the metabolism of oral contraceptives and thus reduce their efficacy. So women who don't want to get pregnant, who are on anti-epileptic drugs, should not be put on oral contraceptives because they're going to be less efficacious than if they weren't on the anti-epileptic drugs. So for those women who are on anti-epileptic drugs, we recommend that they use an alternative method, something like the IUDs. The IUDs are gaining popularity. That's like that levonorgestrel intrauterine system or the copper T. Those are better for those women because we don't have to worry about the interactions. And they're becoming more popular. A lot of women are just getting these and moving off the pill. Lamictal is an important one to bear in mind here. This deserves some special consideration because what we find is that Lamictal gets metabolized faster with pregnancy. It gets cleared out of the body faster. And so if you have a woman who is on a good dose of Lamictal, she's well controlled, her levels are therapeutic, and then she gets pregnant, What's going to happen to her lamictal levels in her bloodstream is that they're going to drop if she stays on the same dosage. And so this is why it's important that these women are in close consultation with their neurologist so that their neurologist can increase their dosage as needed. It's also going to be important that they come in and get their levels drawn of their anti-epileptic drugs. And that's going to go for other drugs aside from lamictal, their dilantin levels, etc. We're going to be drawing these levels because with the changes that happen in pregnancy, it can alter the metabolism of these medications, and if it drops the level too far below the therapeutic range, now you've lowered the seizure threshold and these women are now at risk of having a seizure. There's a couple syndromes that you may want to be aware of. The first is fetal valproate syndrome. I've seen this come up on the test from time to time in practice questions. The major risk here is spina bifida, 1 to 2%. Now you might be thinking that's not a real high amount, 1 to 2%. But when you consider the prevalence of spina bifida in women who are not on this particular medication, this risk with Depakote is 20 times higher. So it is a significantly increased risk. There's some other things that can happen: abnormal facies, underdeveloped nails on the fingers and toes, arachnodactyly, diastasis recti, hypospadias. Remember, that's the one where the urethral meatus is actually coming out the ventral aspect of the penis. Congenital heart defects, tracheomalacia, clubfoot, hip dislocation, and developmental delay. So these things are seen as the teratogenic effect of Depakote. And remember, we really don't use that in women anymore. It used to be used. However, you may run into a patient who has had a heck of a hard time trying to control her epilepsy, and finally the neurologist just settled on Depakote. And so you may theoretically see a woman who's on Depakote who gets pregnant, but it would be unusual. The other one is fetal Hayden-Towen syndrome, and this is going to be with the Hayden-Towen class of medications, which is primarily phenytoin, dilantin. And the major one you see here is cleft lip and palate, and just general midfacial abnormalities. I have seen this one come up on a test question one time on the USMLE Q-Bank. So this one you will want to remember as well. And the reason is because there is a relatively high risk of delivering a baby with one of these abnormalities, usually cleft lip palate, if you're taking phenytoin. It's actually 10%. So if you're on phenytoin, it's a 10% risk of having a baby with this syndrome. A couple other things I want to draw your attention to. Children of women who are on phenytoin during pregnancy have an increased risk of neuroblastoma in childhood. And then there's also an associated risk with vitamin K deficiency in the neonatal period. However, we believe that this risk goes beyond phenytoin, and so for this reason, as we're going to see, we give supplemental vitamin K to women in their final month of pregnancy who are on any anti-epileptic drug to protect their newborns. Patients should continue their preconceptional folic acid supplementation. That kind of goes without saying because those first several weeks after conception is when the neural tube is forming, and so we want them to continue their folic acid into their pregnancy. Screening for malformations should be offered. Now, we do a lot of these things routinely. The alpha-fetoprotein is taken at 14 to 16 weeks. Usually that's taken from the maternal serum. However, it can also be taken through amniocentesis. So if you're doing amniocentesis for any other reason, it would be good to get the alpha-fetoprotein from the amniotic fluid, kind of kill two birds with one stone. It might be a little bit more accurate. I'm not exactly sure on the numbers, but there's no need to do an amniocentesis just to get the alpha-fetoprotein. The maternal serum will suffice. Remember that an amniocentesis is associated with about a 1 in 200 chance of causing a spontaneous abortion. Ultrasound is done at 18 to 20 weeks, so that pretty much everybody gets at 18 to 20 weeks. That's when you can find out the gender of the baby, so moms rarely miss that appointment. But you can do higher definition ultrasounds in women who you're concerned that they may have a baby with congenital abnormalities. Drug levels should be drawn at least twice in the first trimester, and then once in the second and once in the third trimester. And what you're doing is you're documenting her medication levels in her blood, because we're concerned about those levels dropping because of the pregnancy, because she's metabolizing the drugs faster. And so we don't want her to slip below therapeutic range. So we want to keep getting these blood levels so that if we need to make adjustments to her medication, if we need to increase her dosage, we can do that. We should also check the drug levels anytime after a seizure, and that's standard management for anybody who has epilepsy. If they have a seizure, a breakthrough seizure with their medications, you should check their blood levels just to make sure that they're not below therapeutic range. As I said before, vitamin K supplementation is recommended for women who are on anti-epileptic drugs in the final month of pregnancy to reduce the risk of postnatal bleeding in the child. There has been some associated risk between some of the anti-epileptic drugs and a vitamin K factor deficiency. And this is in addition to the vitamin K that we give all babies intramuscularly after delivery. Generalized tonic-clonic seizures will occur despite management in about 1 to 2% of women during labor, and an additional 1 to 2% of women in the first 24 hours postpartum. And that probably has to do with the fact that this is a very stressful event, both physiologically and psychologically, and that can lower the seizure threshold. So despite our best attempts at managing these women, a sizable number still have seizures. And the particularly problematic times, as you can imagine, are labor and delivery and the first 24 hours postpartum, when her body is undergoing a lot of physiologic changes. Most women with epilepsy will have a vaginal delivery. However, there's a subset of women where you may want to consider just doing a C-section. Remember, C-section has all sorts of associated risks with it. I mean, you run all your surgical risks, infection, wound infection, DVT, all that stuff. But we may want to do a C-section on a woman who's had really poorly controlled seizures, especially in the third trimester, because the whole process of labor and delivery is physiologically and psychologically stressful. And some women, when they're under that kind of stress, it's a trigger for their seizures. So you may want to consider it in them. We have a much more controlled situation when we're in the OR, and we don't have the chaos of the vaginal delivery, and so you may want to consider it in those patients. Also, those with a history of status epilepticus when they're under severe stress. Anti-epileptic drug doses must not be missed during labor. That's pretty obvious. So laboring is not an indication to skip your seizure meds. You still need to take them. In the event that a woman who is in labor, or in general who's pregnant, has a seizure, you want to treat promptly with IV benzodiazepines. You'll go right to that. Now, normally when a person is having a seizure, we wait a few minutes before giving IV benzos. We're not going to do that in pregnant women. And the reason we're not going to do that is because as soon as she starts having a seizure, the risk of fetal hypoxia goes up substantially. And so we want to abort the seizure ASAP. So we give IV benzodiazepines. Now you may be asked on a test question, you have a woman who has a seizure, do we give her IV benzodiazepines or do we give her magnesium sulfate? And the answer to that is going to depend on what's the cause of her seizures. If she has eclampsia, let's say she has no history of epilepsy, but at 24 weeks she had a blood pressure of 150/90 and she peed out 500 milligrams of protein in the urine over 24 hours, and she has preeclampsia, and now she's having a seizure. Now she's got eclampsia. This seizure is from eclampsia. Then we can treat with magnesium sulfate. However, if she has a history of epilepsy, no high blood pressure during pregnancy, no protein in the urine, then this seizure is probably due to epilepsy. And in that case, we cannot give magnesium sulfate. We must give IV benzodiazepines. So make sure that you know what the cause is of the seizure. And that really is just based on the history. Continuous fetal monitoring is indicated for at least 1 hour after seizure or an hour after administration of benzodiazepines because of the association of these things with fetal distress and hypoxia. Here in the US, we put women on continuous fetal monitoring routinely, so you probably wouldn't have to worry about that because she's going to be on it anyway. But if you're not, then make sure that you do put her on it if she does have a seizure or if you have to give her benzodiazepines for whatever reason. So in the postpartum period, you want to pay close attention to her medication dosage. If it was altered in pregnancy, you'll want to go back down on that to prevent her from going into toxicity. The metabolism of the medication is going to slow down, go back to the pre-pregnancy rate after she gives birth. So you'll want to titrate her down on the medication, not too fast, but this will mostly be at the call of the neurologist who has special experience in dealing with these medications. You want to counsel the woman regarding the need for adequate rest, sleep, and compliance with medication therapy. A lack of sleep, sleep deprivation, is a trigger for seizures. Lack of sleep lowers the seizure threshold. So, I mean, you take home a baby, you're taking care of a human being here, you're going to be a little bit sleep deprived. You've got to be careful with these women because sleep deprivation can trigger their epilepsy. So they need to make sure that they're taking care of their baby, but that they're also taking care of themselves. On that note, precautions need to be taken to protect the infant in case the mother does have a seizure. So some things that she may want to consider is having another person present while bathing the child, or if you're changing the baby's diaper, maybe change the baby with the baby on the floor rather than on like an elevated table, so that if she does have a seizure, the baby doesn't fall. Things like that. And then most clinicians do agree that anti-epileptic drugs are not a contraindication for breastfeeding. So things like Dilantin and Keppra, those are all fine. The problems that we do run into is if they're on sedating drugs. So phenobarbital, benzodiazepines. A lot of women aren't on these for primary control of their epilepsy. But if they are, then that may be something that you want to consider, maybe counseling her not to breastfeed if she's on those medications, because it can get secreted out into the breast milk, and then the baby can get that into their system. We probably want to avoid that. So if she has her first seizure in pregnancy, so she has no history of epilepsy, she comes in at, let's say, 28 weeks, and she's got a seizure. She comes into the ER. We need to determine what the cause is of that seizure. And remember that epilepsy is a diagnosis of exclusion. So we need to work her up for a cause. Now, what is the most likely cause of a new onset seizure in pregnancy aside from epilepsy? Eclampsia. Eclampsia would be the one that we're most worried about. So that should certainly be considered in our differential. And that'll play a big role in our workup. There's some other things that can cause seizures, brain masses and stuff like that, or cavernous sinus thrombosis, which I've never seen in my life. But it does happen with increased incidence in pregnancy because they're in a hypercoagulable state. But eclampsia is the one that we are most worried about when a pregnant woman comes in with her first seizure. So we're going to get a CBC, we're going to get a CMP, which is just your BMP with your liver function tests. We're going to get a coagulation screen. We want to get protein, urine protein levels, and we'll do a fetal ultrasound. So a CBC, what we're looking for is her platelet levels. That can go down in preeclampsia. We're going to be looking for her liver function tests, because remember that those liver function tests can be, the liver enzymes can be elevated in HELP syndrome. All of these things are part of that eclampsia, preeclampsia continuum. We want to look at her coagulations, because with hepatic dysfunction, which can happen in HELP syndrome, you can get a deficiency in factor. The PTT can be elevated. Of course, we want to measure her urine protein. So all of these things we're really geared at looking towards whether or not this is an eclamptic seizure. So this is just your general workup for eclampsia. And of course, remember that we look at blood pressure too and stuff like that. So this is how you'd want to work up a woman who's having her first seizure in pregnancy. MRI really comes down to, if you really have no idea and you need to look at the brain, the benefits outweigh the risks. When you're dealing with a woman who's had a seizure, we really need to know what the cause is. And so it's unlikely that the risk will outweigh the benefit when you're dealing with a woman who has a seizure. Now, if you're doing an MRI for some other reasons, maybe not. But when you're dealing with a seizure, this is a big problem. And so an MRI may be indicated if you've ruled out eclampsia and now you're thinking about possibly other things maybe organically going on in the brain. So just to recap, epilepsy is not a contraindication for pregnancy, but is associated with higher risks of complications and maternal and fetal mortality. All women on antiepileptic drugs should be on 4 milligrams per day of folic acid to reduce the risk of adverse fetal outcomes. The best antiepileptic drug regimen is the lowest effective dosage of the medication or medications that prevent seizures in a given patient. And I should just point it out because I didn't mention it. It's better to be on one medication than on 2 medications. Some people will be on combination therapy for epilepsy, especially if they've failed single drug therapy. But as far as pregnancy goes, it's ideal that they are on one medication. But that being said, the best regimen is always the one that best prevents seizures in a given patient. There's little evidence to suggest one medication is superior to another as far as teratogenicity, with the exception of Depakote, which should be avoided. Antiepileptic drug levels should be obtained regularly as dosages may need to be increased, especially with Lamictal, and if possible, monotherapy is superior to polytherapy. Okay, I did put that on here. Maternal seizures should be promptly managed with IV benzodiazepines immediately, and then followed by fetal monitoring. And that is all I have for you. If you have any questions, write me a note below. Otherwise, I will see you next time.